Hey, my name is Dr. Nadeem. Today my topic is achalasia. Achalasia is an uncommon swallowing disorder that affects about 1 in every 100,000 people. The major symptoms of achalasia is usually difficulty with swallowing. Most people are diagnosed between ages 25 and 60 years. Although the condition can't be cured, the symptoms can usually be controlled with treatment. Achalasia is characterized by functional obstruction of the esophagus that, that is caused by failed relaxation of the lower esophageal sphincter in combination with absent peristalsis of the distal esophagus. Patients may present with symptoms such as dysphagia for both solid and liquid, regurgitation of undigested food, respiratory complications, chest pain, weight loss, and heartburn. These symptoms result from impaired peristalsis, peristalsis and deficient or absent relaxation of the lower esophageal sphincter, which lead to stasis of food in the esophagus. Treatment aims to disrupt dissect the lower esophageal sphincter to enhance transport of the bolus into the stomach, stomach, stomach. In the modern era of achalasia treatment, disruption of the lower esophageal sphincter is best accomplished by pneumatic dilation using rigid flex balloons or laparoscopic myotomy, and less effectively by pharmacological type agents such as clostridium botulinum toxin injection or calcium channel blockers. An innovative endoscopy method for dissection of the lower esophageal sphincter using a needle knife to cut the muscular fibers from the luminal side. From luminal side was first described by Ortega in 1980. 2 decades later, Pasricha first described the feasibility of an endoscopic submucosal esophageal myotomy in a survival animal model. Finally, a novel successfully performed the first per oral endoscopic esophageal myotomy in humans, which we call POEM, which appear to be substantially less invasive when compared to laparoscopic myotomy. Achalasia is a primary esophageal motility disorder characterized by absence of esophageal peristalsis and impaired relaxation of the lower esophageal sphincter in response to swallowing. The lower esophageal sphincter is hypertensive in about 50% of patients. These abnormal abnormalities cause a functional obstruction at the gastroesophageal junction. In the physical examination is not contributory. Laboratory strategies are non-contributory. Strategies may be helpful include the following in diagnosis of achalasia, barium swallow, in which we see by the big appearance, esophageal dilatation, barium swallow demonstrate demonstrate the big appearance of the lower esophagus and dilatation of the esophagus and stasis of barium in the esophagus. Esophageal manometry incomplete lower esophageal sphincter relaxation in response to swallowing, higher resting lower esophageal sphincter pressure, absent esophageal peristalsis, prolonged esophageal pH monitoring to rule out gastroesophageal reflux disease and determine if abnormal reflux is being caused by treatment. Duodenoscopy EDD, which rule out cancer of the GEJ or fungus. Concomitant endoscopic ultrasonography if tumor is suspected. The goal of therapy for achalasia is relieve symptoms by eliminating the outflow resistance caused by hypertensive and non-relaxing lower esophageal sphincter. Pharmacologic and other non-surgical treatments include the following: administration of calcium channel blockers and nitrates decrease lower esophageal sphincter pressure, primarily in elderly patients who can undergo pneumatic dilatation or surgery. Endoscopic intrasphincteric injection of botulinum toxin to block achalasia release at the level of lower esophageal sphincter, mainly in elderly patients who are poor candidates for dilatation or surgery. Surgical treatment include the following: laparoscopic myotomy, preferably with anterior door more common, or posterior tooth partial fundoplication. Per oral endoscopic myotomy, patient in whom surgery fails may be treated with endoscopic dilatation first. If this fails, a second operation can be attempted once the cause of failure has been identified with imaging studies. Esophagectomy is the last resort. History. Sir Thomas Willis described achalasia in 1672. In 1881, von Michel's described the disease as a cardiospasm to indicate the symptoms were due to functional problem rather than a mechanical one. In 1929, Hoyt and Ray realized that disease was caused by a failure of the lower esophageal sphincter to relax. They, co- they, co- they coined the term achalasia, meaning failure to relax. Achalasia is the primary esophageal motility disorder characterized by absence of esophageal peristalsis and impaired lower esophageal sphincter relaxation in response to swallowing. Bye. Have a good day.